The bile duct has many diseases that occur, and no matter what, you'll have to look at the bile ducts every time we look at a scan. The most common disease is, of course, stone disease, but also we can have infection, cholangitis, or specific types of cholangitis like sclerosing cholangitis, small duct disease. They may also be injured by various methods or by various causes, in particular iatrogenic, and anomalies may also occur. Finally, we'll talk about the various malignancies that can affect the bile ducts. Let's start with benign disease and stones. And stones is one of the most common problems that can occur in the abdomen. They may be present in 20% or more of the population, and the classic risk factors are female gender, obesity, women of fertile age on estrogen or with estrogen production, hypercholesterolemia in middle age to elderly, but any patient of any age and any gender can have gallstones or biliary stones and get complications thereof. This image is of a fluoroscopic percutaneous transhepatic biliary injection of the bile ducts. And we can see two stones here, and they illustrate the typical appearances of stones. Usually there's some bile duct dilatation upstream, but not always. The stones usually stacked close to each other, one on top, and they're often faceted. They often have a geometric appearance rather than being perfectly smooth and round. Also, they often lay asymmetrically in the bile duct, in the most dependent portion of the bile duct. So these are helpful clues that we'll come back to as we look at stones. For example, let's take this case. When I show this case to trainees, they'll often say, oh, there's some soft tissue here in the liver hilum. There's some pneumobilia. I'm concerned about a tumor, cholangiocarcinoma metastasis, and they'll go down the tumor path. But if we look at this, I think everyone can appreciate that here we have a triangle, here we have a trapezoid, here's another trapezoid. They're stacking one on top of each other like paved stones. They're in the dependent portion of the bile ducts. There's crescent of gas anterior to it. And so they kind of look like stones. And we can, of course, look at a non-con CT. There's no enhancement. They're hyperdense in this particular case. So these are biliary stones in a patient with recurrent pyogenic cholangitis. And we can suggest that even if we don't have the non-con exam in front of us. Common bile duct stones, they say, well, a CT is not very good. But actually, if we look at the literature, you'll find it's actually sensitivity is higher than we expect. And it's very easy to see stones when they're calcified, like this. I'd like to point out the bile duct, the common bile duct, and the intrahepatic ducts are often, and some would say up to 50% of the time, often not dilated when there are common bile duct stones, so-called choledocholitis. When there are stones in the common bile duct, like this bile duct is not dilated at all, we can see the stone very well because it's calcified. But don't depend on bile duct dilatation before you start looking for stones. If you don't see a cause of a patient's abdominal pain, they may just not have bile duct dilatation at the moment of imaging. So we fall back on secondary signs of common bile duct stones, and that includes eccentric filling defects. Usually stones, or always, stones are in the dependent portion of a bile duct. They're heavier in specific gravity than bile. Every stone that we've come across, I'm still looking for the floating gallstone. It's been 17 years. Dependent location and a crescent of fluid or gas anterior to the stone, so even in a decompressed biliary system. Here's another case. Bile duct is not dilated. It's completely fluid attenuation, as many stones are at CT. But this is what raised our suspicion. There was a crescent of gas in this patient who has had prior instrumentation. And we saw there was no change in density, but it looked like there was a kind of a rounded opacity in a dependent location, a crescent of gas. So we suggested there may be a stone, get an ERC or get an MRCP. In fact, MRCP saw 3 separate stones stacked one upon each other with a geometric appearance. And so that's the benefit of secondary signs. We can make these diagnoses if we look carefully. And it's not surprising that choledocholitis, common bile duct stones, are missed so often. It's often a delayed diagnosis. And often hard to see by ultrasound. It's very user-dependent and can be gassed out. When we look at MRCP, it's often stated it's 98% sensitive for stones bigger than 3 centimeters in diameter. we have to look at the right images. In this case, all we see is dilated bile ducts and maybe a slightly dilated pancreatic duct. But these are the images we show to surgeons and referring clinicians. What we would like to look at as radiologists are the thin-cut T2-weighted sequences. And here we can see a stone clearly. It's the same patient in the distal common bile duct near the pancreatic head, maybe compressing the pancreatic duct slightly. So we look at the T2-weighted thin sections preferentially over the 3D, but we display the 3D images just to help sell our technology, if you will, to the clinicians, make it more understandable for them. Along with stone disease, we can also have infection of the biliary tract, cholangitis. So here's an example of a patient 1 week prior, and he was normal. We have no abnormal findings. And then 1 week later, he developed acute cholecystitis and cholangitis. There are many differences between the two scans. Can you help spot them? Well, first of all, the gallbladder wall did become thicker, definitely. It's thicker, there's fat stranding around the gallbladder. But what's equally important to look at is the bile duct. The bile duct wall should be imperceptible, both outside the liver and inside the liver. It's a lot like the urothelium of the ureter. You shouldn't see the wall of the ureter. It should just look like a tube of fluid that's completely homogeneous. The bile duct wall should be imperceptible at CT, whereas once there's cholangitis, you can see thickening and hyperemia of this wall and see it very clearly. We can also see fat stranding around the bile duct itself, and these are all helpful findings to let the clinician know there's cholangitis as well as acute cholecystitis. Acute cholecystitis can get out of hand. Simple dilatation of the gallbladder itself can cause stretching of the membranes and therefore damage integrity of the barrier between a bacterium staying in the gallbladder and entering into the bloodstream. And so simple stretching of the gallbladder beyond 5 centimeters in diameter will put patients at risk of developing what we call acalculous cholecystitis without stone disease. So again, the classic findings are a dilated gallbladder, usually more than 5 centimeters in diameter, with gallbladder wall thickening. And these can occur spontaneously in very sick patients, particularly in the ICU. Those with chronic infection, people with obstruction of the cystic duct, or those even with prolonged fasting. In this case, we see a very thick gallbladder wall extends from the inner mucosa here to the outer serosa there. This is all gallbladder wall, and what's even more concerning, we see some areas of very, very poor mucosal enhancement, and that raises the concern of some sloughing or gangrene of the gallbladder itself. These can be treated by percutaneous drainage and antibiotics, and after that, the patient will spontaneously defervesce in a patient with fever of unknown origin and no other finding. And then later on, they can be treated by surgery. So something important to look out for. And even if we see just a dilated gallbladder, more than 5 centimeters in diameter, in a fever of unknown origin patient without any other findings, we can suggest that acalculous cholecystitis is present, and oftentimes simple drainage of the gallbladder can improve the patient's status. Of course, over-distension or infection can also lead to gallbladder perforation. There should be a good fat plane between the gallbladder and other organs. But when we see bowel plastered up against the gallbladder, or if we see a break in the gallbladder wall, we can suggest the presence of a perforation. Also, gas within the gallbladder can be concerning. And of course, we will look for pericholecystic fat stranding as well. So again, the diameter of the gallbladder should not be more than 5 centimeters. This is a Röntgen classic. This is an ultrasound of the right upper quadrant. There's no Doppler on this exam, and it's important not to mistake this for a wall echo shadow complex. What we're seeing is the gallbladder behind the liver, and we can see this dirty shadowing behind some bright echogenic reflectors. What is this? This is not due to stones, which will have dark black shadowing behind it, but rather due to gas. So this is emphysematous cholecystitis. We can see the gas very well on CT, a little bit less well on plain film, but on the ultrasound it's usually pathognomonic, and we can say this patient needs antibiotics. Usually they don't need surgery right away, but antibiotics will often help improve the situation. CT, of course, will be very confirmatory. Finally, this is another complication that can occur. I'll show you the triad. Can you point out all the features of this triad? Well, we have here gas in the biliary tract, pneumobilia. We also have here stones in the small bowel. It's displaced or ectopic location of gallstones. And notice how they're geometric and seem to cluster together. Stones like to be together. But do you see we also see dilated small bowel. So it's a small bowel obstruction. This is a case of a gallstone ileus, where gallstones have eroded out of the gallbladder into the small bowel and caused the obstruction. But with plain films, it's very hard to make a diagnosis of gallstone ileus. Prospectively, it's been shown it's only about 17% of the time will radiologists actually call it. The obstruction is actually right here. And this gallstone looks a little bit different. It's soft tissue in attenuation rather than calcified in attenuation. It's much bigger. It's easier to see this on a CT scan. So rigorous triad, just to review, small bowel obstruction, pneumobilia, and ectopic location of gallstones. They occur in the same demographics as patients with gallstones, female. It's just usually about 20 or 30 years later in life. And a statistic, just for trivia, 25% of patients who are over the age of 70 who have never had surgery and come in with a spontaneous small bowel obstruction, 25% of those patients have gallstone ileus. That was shown on 2 separate large surgery series of patients. So if you've never had surgery and have a spontaneous small bowel obstruction, you should think about gallstone ileus. In reality now, I think most of us have switched over to CT because there are so many features of gallstone ileus on CT. First of all, we can see the fistula between the gallbladder and duodenum, or between the gallbladder and the colon, or other portions of bowel. You can see often a common fluid level. We can see contrast go from the bowel into the gallbladder. And also we can see the actual gallstone at the transition point. So here's 3 different gallstones. This one's fluid or bile attenuation, but has a thin eggshell calcification around the outside. This was the one I showed you. It's a soft tissue attenuation stone, but it has a lamellated appearance. It looks almost like an intussusception, but there's no fat in there. And so that's easy to pick out as a stone. And even this one, it's bile attenuation. It has a lamellated appearance, and the stones have to be big. You're not going to have a gallstone ileus from small stones. We can easily tell that this is a real stone. So gallstone ileus, if you suspect it or if you're not really sure, just get a CT scan. A few pitfalls to point out. Let's say someone shows you this case. Says, oh, I did an MRI. There's all this gas in the gallbladder wall. Must be emphysematous cholecystitis. This patient needs antibiotics. And you say, wait a minute. Several things can be dark on MRCP, including calcium. This is a case of a porcelain gallbladder with extensive calcification of the wall of the gallbladder. The early writings on porcelain gallbladder suggested that there was a higher risk of developing adenocarcinomas in these patients. The more recent publishings on this topic suggest that there might be a risk, but not much higher than that of the background. So there are some surgeons, if they see the word porcelain gallbladder, they'll recommend a cholecystectomy, but really it should be played based on the patient's expected lifetime, length of lifetime and health. So if there is a risk, it's probably only slightly above that of the background population. But again, black is not always air at MR, and also air is quite difficult to see at MR, so stones and gas can be mistaken for each other and have to be looked at in context. CT, of course, is very easy to tell porcelain gallbladders from gas. Another pitfall is this. Here's a cholangiogram. We can see the small branches of the bile ducts, common hepatic duct. Oh, there's a black band, what looks like a stenosis across the common hepatic duct. What do you think about this? Well, this is a biliary pseudostricture. There's a common reason for the stenosis. It's the right hepatic artery that crosses the bile duct right at that location. And at imaging, there's often a band-like impression, very narrow in diameter, that occurs here or may occur a little bit up higher, sometimes a little bit down lower, maybe diagonal. But if you see just a band-like area without upstream duct dilatation, don't worry about it. Don't report it on your MRCP or CT report. It's just a normal variant, not worthwhile mentioning. Here's an MRCP with a similar crossing hepatic artery indentation. Don't mistake that for a real stricture or web. And the other thing is sometimes at MR or sometimes at ERCP or other imaging, you may see a filling defect. So this is a post-cholecystectomy injection. And our surgeons and most surgeons will inject the cystic duct after they do a cholecystectomy just to make sure the common bile duct is clear of stones. And this was suggested as a possible stone in the distal common bile duct. But then we said, well, keep injecting, and they did, and it was just the ampular vater, or the sphincter vodi, being contracted temporarily and opened up, and it was actually just a pseudocalculus sign. What we want to see is contrast flowing into the duodenum without any obstructing stones after a cholecystectomy. So beware of that variant. Okay, let's move on to the upper ducts. We can divide disease into small duct disease and large duct disease. When we see small irregular bile ducts, normal bile ducts should be smooth and graceful and just slightly curved, uniform in caliber and gradually tapering as we get deeper into the liver. This bile duct is irregular. The common bile duct has these odd sacculations and strictures. The intrahepatic duct has these odd strictures. This area is narrower than that area, which is deeper in the liver. It shouldn't occur, so there's another stricture. There's multiple strictures. And when we see this, we automatically think of this differential diagnosis. Primary sclerosing cholangitis is probably the most common cause of this appearance. It usually involves the intrahepatic ducts as well as the extrahepatic ducts. And words that we use to describe it are beaded appearance with alternating strictures and areas of dilatation. They may or may not have biliary diverticula, and we'd be concerned about development of a cholangiocarcinoma. Something that can look exactly like this is ischemic bile duct disease. That can occur after trauma, a liver laceration near the hilum, or chemotherapy to the hepatic artery, or other embolization that may have happened to the hepatic artery. Ischemic duct disease can look exactly like primary sclerosing cholangitis. AIDS cholangiopathy can also look just like this, except we just don't see that very commonly anymore. We did see it very commonly about 10 to 15 years ago, but now with the multi-drug treatment, we just don't see it very often. And a particular feature is papillary stenosis that occurs with AIDS cholangiopathy, which will be down here, but otherwise it looks very similar to primary sclerosing cholangitis. Papillary stenosis tends to occur in AIDS cholangiopathy, but not the other ischemic or primary sclerosing cholangitis. And finally, some other diseases can also give this appearance, but we usually think about sclerosing cholangitis and maybe ischemic in reality. This is a progressive disease that inexorably leads to cirrhosis. It can take about 4 to 10 years to occur. It's kind of like having a slow cancer and eventual liver failure. They occur in young patients, often male, and often with inflammatory bowel disease, although only a small fraction of patients with ulcerative colitis have primary sclerosing cholangitis. Most of the patients with primary sclerosing cholangitis have inflammatory bowel disease, ulcerative colitis. And the complications will include cirrhosis and eventual other infections and also cholangiocarcinomas. Cholangiocarcinoma is going to come up as a concern for almost every bile duct process. So if you had stones, if you had instrumentation, prior infection, inflammation, they're all risk factors for cholangiocarcinoma. So just remember that in your mind. The only exception is primary biliary cirrhosis. Here's an example of another duct disease. These are big ducts. So what do we think about when we have large duct disease? These are dilated ducts, but they have these kind of odd filling defects. They're lamellated. They seem to be sitting in a dependent portion of the duct with crescents of bile anterior to them. There may be some pneumobilia anterior to these filling defects. These are stones. And we see multiple stones in dilated intrahepatic ducts with maybe very peripheral bile duct sparing. What do we think about? This is typical in appearance for recurrent pyogenic cholangitis. This is a typical ERCP attempt at removing one of these large stones with a basket. Quite difficult to remove. They're putty-like, very soft stones, and will require chronic mechanical extraction of these stones as these patients develop chronic relapsing cholangitis. Recurrent pyogenic cholangitis used to be called oriental cholangiohepatitis, occurs vast majority of the time in patients from Asia. There are sporadic cases in the Western world and may be associated with intrahepatic pigment stones and coliform bacterial seeding, gram-negatives. Although, kind of more luridly, it can be also associated with parasite infections like Ascaris or Conorchis in particular. But that's a minority of patients. Many of these patients just have bacterial infections. Another case, we see multiple filling defects in dependent portions of the bile ducts, relative peripheral bile duct sparing. Here's a crescent of bile anterior to a small stone. We can make the diagnosis of stones quite easily. Again, centrally, the bile ducts tend to be dilated, peripherally not so much, and we look for liver abscesses that may need to be drained and bile duct stones that may need to be extracted, and of course, cholangiocarcinoma. We can also get bile duct abscesses with any type of ascending cholangitis. Ascending means it came from from reflux of material from the duodenum. Usually these are gram-negative bacteria, again, coliform bacteria. They can be associated with stones or stents or any type of instrumentation, or maybe tumors that change the geometry or function of the sphincter of Oddi, or acute pancreatitis. It's not a radiological diagnosis, but we need to look at clinical features such as pain, fever, and jaundice to help suggest the presence of cholangitis. We will look for bile duct wall enhancement, and that can help the clinician make the diagnosis that there is an infection or inflammation of the bile ducts. Bile duct wall inflammation is nonspecific, however, can be seen with tumors as well as infection. Here's another large duct disease. There's a very large duct here, common bile duct and common hepatic duct, but the intrahepatic ducts really aren't that big. So when we see a saccular or fusiform or other enlargement of the common bile duct, but the upstream ducts are not particularly big, we think about choledochal cysts. And choledochal cysts come in many types and forms by the Todani classification, but I tend not to get too much into detail because in reality the treatment of the choledochal cysts are essentially the same. We try to resect the entire cyst if possible because the cyst is at risk for developing a cholangiocarcinoma early in life, meaning in your 30s and 40s and 50s, rather than in your 60s and 70s. So you have these healthy young people come up with a terrible cholangiocarcinoma. So we try to resect the entire cyst, and we try to resect any connection between the bile duct and the pancreatic duct. So in this case, we can see the pancreatic duct coming in, bile duct coming in, and it seems to emerge. Is this more than 1.5 centimeters in length? If it is, that's a common channel, and that's a risk factor for developing cholangiocarcinoma. It's very hard to measure on the MIP image, although the MIP image is very pretty. We go back to thin section images. We can see the common bile duct coming down, pancreatic duct here. Here's where it joins. And then we can measure this length very accurately, and oh, by the way, there's also a stone in the common channel. So we can then say, we have a choledochal cyst, a stone, and a long common channel that needs to be separated so that pancreatic juice doesn't reflux into the biliary system and increase the risk of cholangiocarcinomas. So please remember that it's becoming increasingly clear as there's more publications, mostly from Asia, on this entity. Choledochal cysts are often diagnosed as patients are infants, but can also be diagnosed later in life. Just a simple diagram of the different types. You might have to memorize them just to show that you know your stuff, but in actual fact, we just want to call choledochal cysts, and it doesn't matter if you get the type exactly right or not. This is a choledochal cyst. It should be a big fusiform cyst, but look, there's a giant cholangiocarcinoma filling this cyst, and here it is on CT. This is a 29-year-old woman. She was totally healthy, looked great, had her whole world in front of her, and the surgeon had just decompressed her biliary tract by suturing her duct to a piece of duodenum, thereby curing her symptoms when she was a baby. And then she never had a completion cystectomy. And we get about one case every year, every other year. It's really sad. It could have been prevented had the entire cyst been resected. So that was a fatal cholangiocarcinoma in a very young patient. Let's move on to iatrogenic injuries or bile duct injuries. This is an example of a patient who has had a cholecystectomy. We can see the cholecystectomy clips. And it's funny, there's a little duct here, looks like a right duct, that is leaking contrast into the cholecystectomy bed. And this is called a bile duct leak. And it's hard to fault the surgeon for this because it was actually an anomalous bile duct connection directly into the gallbladder. And that can occur with the right posterior duct in particular. And this type of leak can be treated with stenting or, in unusual cases, just put a bile duct stent across and try to improve flow into the common bile duct. May go away on its own, or occasionally will require a partial hepatectomy to cure. But biliary leaks are a constant occurrence with cholecystectomies. It occurs in a few percent, 0.5 to 5%, regardless of the experience of the operator. The presentation is very variable, and the leaks may lead to only very, very vague abdominal symptoms, kind of a little bit of bloating or discomfort, nothing in particular that is urgent. It may take months to find the leak. So the leaks are unusual, and we want to kind of diagnose them just so that we can watch them and maybe manage them expectantly. So a good way to diagnose them is by ERCP, retrograde injection. We can forcefully see whether contrast will come out into the cholecystectomy bed or otherwise. Percutaneous methods or scintigraphy has been shown to be helpful to find leakage of bile into the peritoneal cavity. Or maybe using hepatobiliary agents at MRCP or hepatobiliary agents at CT, we can then see the leakage of contrast from a bile duct into a biloma. When we do these studies, it's important to clamp your drain. If you don't clamp the drain, oftentimes the contrast will go into the leak and come right out the drain, and we don't really notice it because the drain is causing some artifact that prevents the leak. So it's very helpful to clamp the drain a few minutes or even an hour before the study so that the collection starts to fill up and so you can see the leakage without disappearing off into the drainage catheter. So the right bile duct variants almost always affect the right posterior duct. This is a mischievous duct. About 50% of the time, or some people say only 45% of the time, the right duct actually joins with the right posterior duct will join with the right anterior duct to form a right duct. But the other half of the time, the right posterior duct has a mind of its own, can insert directly onto a common bile duct. It can insert on a cystic duct. It can, on the cystic duct or into the gallbladder itself, it can also insert into the left bile duct or may form a trifurcation pattern. There's many right posterior bile duct variants. And the ones that we care about for cholecystectomies are the ones where they insert into a cystic duct or directly into the gallbladder itself. And in Japan, there are some groups that will do a CT cholangiogram or do high-resolution imaging just to try to prevent these complications. But in America, it's a little unusual to do that type of preoperative evaluation. Let's look at another type of injury that can occur. This is another person with a cholecystectomy, and a retrograde injection of the bile duct was performed, and I just don't see the common hepatic duct or the intrahepatic ducts at all. The surgeon inadvertently ligated the common bile duct. This isn't as uncommon as you might think. Injury to common bile duct may occur anywhere up to 1.2% of the time after laparoscopic cholecystectomy. It may be associated with a leak or may be associated with obstruction. And it may be associated also with an aberrant cystic duct that inserts posterior and medial on a common bile duct. And so when the surgeon sees a duct, he says, oh, there's my cystic duct, inadvertently ligates that duct, or they have poor visualization. So for whatever reason, we do see these on a regular basis. And the types of injuries are classified based on the bismuth classification. It's probably useful to memorize the first couple of locations. These are in order of difficulty of repair. So what's the easiest one to repair? If you just happen to ligate or injure the bile duct near the cystic duct, so it's kind of far away from the liver hilum. You can imagine if you start to injure the bile duct higher up, it's much more difficult to repair. So that'll be a type 2, not a type 1. Or if the entire hepatic duct is injured, that's a type 3. And then if you hit the hilum, then that's a confluence. That's the entire duct. Let's move on to the tumors. There's adenomyomatosis, gallbladder polyps, and gallbladder cancer. Adenomyomatosis involves multiple cyst-like areas of the fundus of the gallbladder, and it's extremely common, 7% by autopsy. We may see a string of pearls, very bright T2-weighted signal on a gallbladder on the sagittal view or coronal view, and we may see little cystic areas by ultrasound, although quite difficult to identify on ultrasound with clarity sometimes. But the small cystic areas are dilated Rodicanchi-Aschoff sinuses, are pathognomonic for adenomyomatosis. We don't have to worry about cancer in those cases. So we'd be an extremely unlucky radiologist if that were cancer. If we see this, it's adenomyomatosis, and we don't usually follow those patients up unless they have secondary symptoms. Something else that's not too uncommon is polyps. On non-contrast CT, we don't see enhancement. On post-contrast CT, we do see enhancement and washout. The polyps, how do we treat them? They're not exactly the same as colon polyps. Colon polyps, they progress to cancer with a very set stage, but gallbladder polyps, only a small minority will progress to cancer. And so generally, we will do a cholecystectomy if the patient has symptoms or if their size is bigger than a centimeter, or if they have coexisting gallstones, maybe slightly higher risk of malignancies. But otherwise, ultrasound surveillance is reasonable for gallbladder polyps and doesn't require cholecystectomy. What do you think about this case? Sometimes people will show you an exam that you're not really familiar with looking at, but you know the radiology features. This is a gallbladder with a fungating irregular mass. That's not a gallstone. So you have to be concerned that there is a growing mass, either a metastasis or a primary tumor. This is a gallbladder cancer involving the gallbladder wall. It's very irregular, and usually at the time of diagnosis, there'll be lymph nodes and distant spread with liver invasion. This is a deadly cancer with a 5-year survival less than 1%, mostly because by the time we find them, they're widespread. They're associated with elderly patients or patients with gallstones. And again, the very poor prognosis. For example, here's a patient with relatively small tumors, but already we have lymph nodes in the liver hilum and the retroperitoneum. This patient did not survive 1 year. Other things that we can look for, types of cancers, are malignant bile duct strictures. I'd like to point out a few features of bile duct strictures that we are concerned about. We want to, for malignant strictures, they usually will not have a gradual tapering of the bile duct. It will have an abrupt shoulder. The narrowing will not be concentric, it will be eccentric. This is an eccentric narrowing of the bile duct, and often longer segment. In this region, we can think about cholangiocarcinoma, but also think about gallbladder carcinomas, which can cause lymphadenopathy in this region, or pancreatic cancers with lymphadenopathy in the local region. It's helpful to get a CT or MRI scan for further evaluation. Possibly trauma or other benign features benign causes can give a similar appearance, but very unusual. What I'd like to point out is, because cholangiocarcinomas and bile duct cancers in general have relatively few cells, they're very scarce, have fibrous tissue, the sensitivity for biopsy and cytology and brushings is low. It's around 50%, meaning that if you were to do a brushing, chances are half the time that you have cancer, you didn't pick it up. So if you were to do 2 biopsies or 3 biopsies, your chances of picking up the cancer are about 75 to 88%. So a lot is based on our interpretation. If it looks like a malignant stricture, we say it looks like a malignant stricture, even if the biopsies and brushings were negative, because we want continuous surveillance. We really want the tumor to declare itself as benign, and rather than us miss a potentially lethal cancer. So if it looks malignant, abrupt shoulders, eccentric location, then we will continue to follow these patients. A very common type of tumor is a Klatskin's tumor that occurs right at the bifurcation of the right and left ducts. For some reason, tumors, cholangiocarcinomas like to sit in this location. We can see it by MRCP or CT. And other types of cholangiocarcinomas are peripheral masses. The peripheral mass cholangiocarcinomas have a typical appearance. They're not just a round mass like a metastasis. They often will have a scurous, retractile appearance. They'll pull in the liver capsule. Often, they are also associated with bioduct dilatation if they're somewhat central. So they'll see little dilated ducts nearby. And the dilated bile ducts will often have little tumor fingers that crawl into the dilated bile ducts, and these are typical features of a cholangiocarcinoma. They may also enhance on 10-minute delay because of all the fibrous tissue will entrap contrast material. I apologize, I'm running a little bit over time, but we'll make it up on the unknown cases, so I do apologize. Cholangiocarcinoma, well, this is a typical case, has a retractile appearance of the liver capsule, dilated bile ducts. It's very unusual to see dilated bile ducts with most metastases to the liver or even hepatocellular carcinoma. So if we do see bile duct dilatation, we think about cholangiocarcinoma in a differential, if not put at the very top of the differential. So capsular retraction, large mass, duct dilatation. Here's another example. Bile duct dilatation, we're immediately thinking about cholangiocarcinoma. And here's a mass with a finger of tumor crawling along the bile duct, typical for cholangiocarcinoma. And yet another mass with bile duct dilatation, we're thinking about cholangiocarcinoma. And we can see fingers of tumor crawling along the bile duct, or here's one in the common bile duct itself, very typical for papillary form of cholangiocarcinomas. So in summary, we've covered the most common benign diseases. Please look for stones even in non-dilated bile ducts. We've also covered various infections. Look for bile duct wall enhancement and fat stranding around the bile ducts themselves, as well as complications. For all of these benign entities, please look for cholangiocarcinomas, which can be a complication.